Welcome to Momentum for Change, Voices of the Missouri Movement. This is a monthly podcast produced by your coalition, and I am your host, Nora Mosby, a member services specialist at the Missouri Coalition Against Domestic and Sexual Violence. We hope that you enjoy this conversation coming to you directly from Voices of the Missouri Movement. Some episodes of Momentum for Change have conversations that include content and descriptions of domestic and sexual violence, which may be alarming or activating for some listeners. Please take care and visit the MOCADSV website or call our office to connect with supportive services. Hello and welcome to episode 5 of season 4 of Momentum for Change. This is your host, Nora Mosby, and I am really looking forward to our conversation today. We are going to be talking about maternal health and the way that it intersects with domestic and sexual violence. So many survivors of domestic and sexual violence may be seeking care for mental or behavioral health conditions, and many of these survivors might also be pregnant. Mental health, pregnancy, and domestic and sexual violence are issues that are deeply connected on many, many levels. So we are joined today by Dr. Melanie McKean with the Maternal Health Access Project to discuss these connections further. The Maternal Health Access Project is a statewide perinatal psychiatry access program. They view pregnancy as an opportunity to help, and throughout our conversation today, we are going to be talking about what these opportunities and services look like. Dr. McKean, thank you so much for joining us on the podcast today. As we're getting started, can you introduce yourself to listeners and tell us a little bit about what you do?
Sure. Nora, thank you so much for inviting me today. So like she said, my name's Dr. Melanie McKean. I'm one of 3 reproductive psychiatrists that provide the consultation arm of the Missouri Maternal Health Access Project. We went live about a year ago, April 1st of 2024, and provide 2 main focuses. One is psychiatric consultation for individuals that work with pregnant and postpartum women in the state of Missouri and providing help with diagnostic modalities, treatment recommendations, those sorts of things. And then there's another arm that provides a lot of other wraparound services that are at a dearth, in our state. In addition to that, I have a private practice, McKean Reproductive Psychiatry. I opened that in January of 2024. And that was kind of my passion project from my professional career to really focus and hone in on reproductive mental health. And when people ask kind of what that is, essentially I see women with any sort of mental health concern, predominantly mood and anxiety, anywhere from like things with menstrual periods, certainly pregnancy and postpartum, see pelvic pain, female cancers, perimenopause. So I do that as an outpatient. I also the psychiatrist for the local plumbers and pipe fitters union and provide kind of general psychiatric services there. So I have my toes dipped in a few different areas.
You certainly do. Those are so many interesting things. And speaking of interesting things, I have to say, when we think of psychiatry, we don't always think specifically about reproductive mental health. So how did your interest get sparked in specifically looking at maternal health and reproductive mental health? Where did that come from?
Yeah, I'll try to keep it as brief as possible. It's kind of a little bit of a convoluted sort of path. So originally I was going to be an OB-GYN, and that is what I went to med school for. And I was doing a research project along the way in reproductive mental health. In reproductive health. So I was going to do an OB-GYN residency and a reproductive endocrinology and infertility fellowship. So I did a PhD dissertation on differential gene expression in women with and without endometriosis, which has nothing to do with ultimately, this career path. But I think all of that time and interactions with people in this space helped me to realize that what I really enjoyed was learning people's stories and talking to people. So ultimately, when it came time to apply for residencies, I ended up applying for an internal medicine psychiatry residency programs and some general psych, but ended up doing a internal medicine psychiatry residency program at Rush University in Chicago. And I really, really felt connected to that program because there were faculty on staff there that could let me do a women's health focus in both arms of that. So when I had electives in internal medicine, I could do things like breast cancer and like pelvic floor PT. When I had Psych, neighboring UIC literally has an outpatient clinic and an inpatient treatment team that do reproductive mental health services. So I still got to kind of stay in the space of obstetrics and gynecology, but I serve like a different support. So that's kind of what got me there.
That's so interesting. And I love hearing about how it really came from an interest in hearing people's stories and talking to people and connecting with people. I can certainly relate to that with a background in advocacy. And I think when you are there for people during challenging times, such as challenges with mental health during or after a pregnancy, you really can make such a huge difference in their experience. I can also relate to that feeling of just wanting to connect to people and hear their stories.
Yeah.
So I think when we are working with people and really in the relationship building game, we come to this work with a certain approach or maybe certain philosophies that guide and inform our work. Is there anything that you would say about the approach you take with your clients?
Really, what I've learned over the years and one of my main goals in working in this space is that these things can happen to anybody. Certainly, if you have certain situational stressors, you are obviously at a higher risk. You're kind of set up, unfortunately, for having more difficulties and challenges with mental health, or should you have a mental health issue. But I've seen it run the gamut. I've seen folks in the lowest socioeconomic class. I've seen folks in the highest socioeconomic class, and these things do not care how much money you have. These things do not care what the color of your skin is. They do not care where you live. Perinatal mood and anxiety are the number one comorbidity of pregnancy, or if you're not pregnant, of infertility, of all of those things. Like, they are the most commonplace things. And there's still so much stigma. There's still so much negativity around being open and honest about mental health and seeking it, and a lot of fear and misinformation. So my approach is to dispel all of that. And my approach also is to help, just in the area of psychiatry, to not have us viewed just as people who prescribe medication. Because I definitely meet with people and I don't prescribe medication, and not because they didn't want it, because I didn't recommend it. So I think it's also dispelling myths about seeing a psychiatrist and what that means.
I am so on board with everything you just said. We are doing a lot of that similar work within the anti-violence movement, just trying to be accessible to people from all different backgrounds, because yes, domestic and sexual violence also impacts people regardless of who you are, what access to resources that you have. And we do know that, of course, it doesn't impact everyone in the same way, but that it does impact all people. And so it's really important to be accessible, and that those myths that are out there can get in the way of people accessing services that could be potentially life-saving, as with your mental health care services. And so I'm so glad you spoke to those issues and described your approach in such a way. I would love to get to know a little bit more about the Mental Health Access Project. So for people that might not be familiar with perinatal psychiatry, could you tell us a little bit more about what the work of perinatal psychiatry is?
Sure. So we kind of are a subspecialty area within psychiatry that's really focused on all of the comprehensive issues that can occur between reproductive health. People usually kind of think of like, oh, how my hormones are affecting my mental health, and all of the ways that can be impacted. Now, this Access Project is predominantly focused in the area of helping get access to care and treatment for women who are pregnant or postpartum. But in the whole scheme of things, it can be depression premenstrually, so premenstrual dysphoric disorder falls under this. Any sort of health concerns that have maybe an interaction with hormones, so things like polycystic ovarian syndrome, endometriosis, those sorts of things. I see a lot of folks in my private practice that are referred from the different infertility clinics in the area, because in addition to just like the struggles with dealing with infertility in and of itself, a lot of the protocols for reproductive endocrinology and infertility involve exogenous hormones, which can have their own impact on mood and anxiety. And actually, we just came off of National Infertility Awareness Week, which was last week. And so I worked with one of the local organizations here to provide some information about seeing a reproductive psychiatrist if you're going through that process. Certainly the bread and butter is mood and anxiety during pregnancy and postpartum. But then I've been seeing a lot of perimenopause, because if you can, if it makes sense to you, if you've had issues with mood and anxiety related to your menstrual periods, or maybe you've had mood and anxiety related to pregnancy and postpartum hormonal fluctuations, then when you hit perimenopause, you can imagine that that's its own its own kind of, it's been called chaos. And a lot of that's because of how your hormones are interacting at that phase of your life. And of all of those things, it's the one that actually is the most consistently bothersome, because PMDD can last a few days and postpartum depression maybe weeks to months, but it can be a decade of your life to be dealing with mood and anxiety amongst all of the other physical symptoms with perimenopause. So that's a huge area that I've been involved with in these last couple of years, because it's really gotten a lot more awareness of the need. Any person who's ever started their period has to end it. So that's even more common than people getting pregnant and being postpartum. So
interesting.
So that's kind of all the areas that a reproductive psychiatrist, and there's certainly others that I know. Sexual health, that's another area that if you either decreased libido, or again, trauma impacting sexual health. So those things can be areas that a reproductive psychiatrist can help with.
So there's a lot that goes into perinatal psychiatry is what I'm hearing.
Yeah.
So you mentioned before that the Mental Health Access Project is a relatively newer project, and many new projects that are launched are seeking to fill a gap in services or meet an unmet need. So what is that gap in services that the Mental Health Access Project was seeking to just...
Well, across the country, there is poor access to mental health. There aren't enough people that are working in this space, or even if there are a lot of people, just access to that care, because, the vast majority are kind of in maybe more urban areas, which that isn't the majority of the country. So as far back as 2014 in the state of Massachusetts, they started their own, it's called MCPAP for Moms, but their own program that was addressing mental health and just maternal health all around in the state of Massachusetts. And then over the last 10 plus years, we have currently about 25 of these access projects throughout the country. So about half of the states have one, which still means that there's a lot room for growth. So in Missouri, it was launched because, as you can imagine, we don't have a ton of urban areas with a lot of access to healthcare. You've got Kansas City, you've got St. Louis, and then you've got a few other smaller cities, but a lot of Missouri is rural. And there's a lot of barriers to care, whether that is literally being able to find somebody that works in mental health, whether that's a therapist or a psychiatrist, but also maternal health too. There's areas of the state that have limited to no obstetrical or gynecological care. So while we're focusing on the mental health piece of things, it's to provide that access theoretically statewide to every single city and county, because we are available anybody that works in that space. And you don't have to be a physician. You don't have to be somebody that prescribes medication. You don't even have to be a quote unquote mental health provider. It can be a nurse. It can be a doula. It can be a home health, so parents as teachers. We have a lot of them that have registered with our program. Anybody that interfaces with pregnant and postpartum patients or clients and wants some help in guiding them towards more access to care. So when you either online or call in to a consult with our line, you can either opt for the choice where you, again, get a consult with one of us, because maybe you have a much more specific diagnostic question, or maybe medication management, trying to support them with that until they're able to get in with a physician or a specialty provider. But then there's also an arm of it that either we can refer folks to, or directly clinicians that are registered can get this access to our coordination care program, which could link people if they need a therapist, if they need a group, if they need a variety of other support services. Our care coordinators are available to provide that help, either to the person who calls in for the consult, or if the individual is willing, then our care coordination team can directly reach out to that person to help provide them those services.
Great. So I would love to back up just a little bit. Many of our listeners are domestic and sexual violence advocates and are interfacing with pregnant and postpartum survivors of domestic and sexual violence every single day. Do you think that they would be a good fit to get registered with the Maternal Health Access Project?
Yes, definitely. Because they may not necessarily so much be wanting the psychiatric consultation, but definitely for the other care coordination piece. Like if they feel like their client, it needs, again, like a therapist that's specialty, that's again, somewhere in like the postpartum space. Or if they do feel like they really need to see a physician because they're having a lot of depression or anxiety and they are pregnant or postpartum, then, asking for help with those services. So definitely.
And what does that
Definitely any of them could register.
what does the registration process look like?
It's pretty straightforward. I don't know if you've already received a link from anyone with our team, but you go to, if you kind of like Google the Missouri Maternal Health Access Project, or it's through like the MU's website, there is an area you get on there and it'll say like MHAP, which is the acronym for it. And it says like register now. And you click on that and it doesn't take very long. It's just like a handful of questions. It's free. It's mostly like just a little bit of demographic information, like what's the email that you would want your treatment synopsis sent to, because when they do consults with us, then we do a short like synopsis of the call. So like phone number, name, email, location, like what you do if you are a therapist or again domestic violence worker or something like that. So it takes less than 5 minutes to sign up. I think it's more like 2 minutes. And it's free.
Okay, that's great. Dr. McKean, you might not be aware of this, but domestic and sexual violence advocacy programs have to abide by pretty strict confidentiality standards, similar to HIPAA, not exactly the same as HIPAA though. So could they get information through the Mental Health Access Project without releasing the patient's contact information and name?
100%. In fact, most of the time, I don't ever know who I'm helping a clinician, but most of the time, like patient info, it's only if the patient has agreed to that for then the clinician to provide to our access project. And that's for the care coordination arm. But that would be something that would be asked, but you do not have to put in any patient identifying information to do any sort of like consult or receive any sort of services. And you can do a like callback or request services for the same case over and over again. You could do 10 cases in 10 days. Like any and all access.
Okay, great. That is wonderful to hear. So after a organization or agency is registered with the Maternal Health Access Project, what services are available once they connect with you all?
So they can moving forward, they can either do one of the consultations. They can also attend, like later today, I'm going to be doing a presentation on like preconception counseling with depression. So our psychiatrists, like periodically, right now it's quarterly, provide some sort of kind of live education. And then we also, again, have the care coordination services. And then long term, as we are in place more and have done more of the toolkits and presentations and things like that, there'll start to be literally like an online database available to anybody who's registered. So you can also register just to get all that educational content and never actually do a consult.
Okay, great. Well, I will go ahead and share that registration link in the show notes for this episode. So any listeners who are listening can easily access that registration information. And I'm just really excited that this is a resource available to agencies who are working to support pregnant survivors of domestic and sexual violence. And so you've talked about some of the mental or behavioral health conditions that perinatal patients might be dealing with. Is there anything else you wanted to say about what those conditions could look like or what support you're available to respond to or with?
Well, I think we talk again a lot about mood and anxiety. So we think about like depression and anxiety. And again, those are the most common presentations, but we certainly can help with guidance on help with other sorts of issues. So whether that would be like trauma or OCD or again, like sexual health and those sorts of things. There's such a variety of things that we can talk about, even personality disorders, things like that. So oftentimes if, somebody who has maybe like no education at all in mental health is kind of feeling stuck in interacting with someone, then we might be somebody that could help at least provide some assessment. So that's some of what we do in those consultations. It's not always about medication. Sometimes it's, well, maybe here's like some assessment tools and you could use those to help you to figure out like what's going on with that person.
Okay. And I was wondering just kind of about your organizational structure. Like, are you all a nonprofit? Where do you all get your funding
So
from?
we're funded by two main funding sources. We have a federal grant, and then we also have like a state line item grant as well. So that's why it's free to the community, to the state, because these are supported by grant services.
Oh, that's so great to hear. And so, as a psychiatrist with the program, what is your role specifically in responding to these agencies that are registered?
So on Mondays is when I am the psychiatrist that's available for consultation. So essentially, one of us is available 9 a.m. to 5 p.m. Monday through Friday. So I am the individual available on Mondays, and you can either call in and request a consult back, you know, anywhere within like 30 to 60 minutes, or most people use the option of you can just literally schedule it. So they will have like a schedule block of on the half hour, an hour, where you can schedule a block of time with us. And then we get a notification, and then we call you back at the number that you're registered at to do that consultation. So when I get a consult, I get a notification about that, typically, well, sometimes even days in advance, because you don't have to do it the same day. Let's say you see a case on Thursday, but you're like, I don't have time to actually call in to do this today with my workflow, but like Mondays on 1:00, I do. So then they could get on the site anytime and book like the time that they wanted. And then I would get that information, and then I would have it. And at 1:00, I would give you a call. And I usually just start the calls by confirming that I do have on the line who's registered, and then just asking like, how can I help you? And then we just kind of go from there. And sometimes it's less than 10 minutes. And sometimes like my longest one has been like 40 minutes because it was a pretty complex case. And the clinician calling me needed a lot of support in kind of figuring out next steps. And sometimes that is all we're doing, is figuring out next steps, because sometimes they have minimal information that they're calling us about. And that's why they are calling for that support, is because they really are at a somewhat of a loss and really looking for help. So I really approach it the same way I would have when I was in residency, and even in attending, working in an academic medical center. You try to look at everything as like somebody's just asking for help because they don't know what to do. And that's why they're calling.
Yes, absolutely. So it seems like a very user-friendly process. Could you give us an idea of maybe what some common issues are that people may be contacting you for, or just a typical call you might get? Any common issues that come up?
So a lot of the calls I get are, well, so I'll be honest, like my Mondays and Fridays seem to be like the lowest census day. So I've had like the least amount of calls. So it's hard for me to say like the most common situations. But I would say that I've had certainly a couple of situations where it wasn't about medication per se. It was about an individual with anxiety and how best to support them while they waited to get in with a therapist. So it was a doula who was supporting their patient, their client, in a certain way, but recognized that they were going to be needing some higher level support than what they were able to provide. And that while they were waiting to see their OB-GYN for the next time, or wait, like helping them to help their client or patient advocate for themselves when they went to their next appointment. Like, what would those kinds of questions be that they should ask? And then also asking for the care coordination arm to actually link them with a therapist and psychiatrist in the meantime too. But so sometimes it's helping individuals that don't necessarily work in mental health at all to know how to help their patient or client advocate for themselves to then get that other help. And then beyond that, it's been a lot of somebody like going into labor or immediately postpartum, and they're in the hospital and they don't have maybe a psychiatry consult service to come by and provide guidance, and kind of like some immediate sort of help with getting somebody in a much more stable place to then be discharged home and linked with care. So those are kind of the two most common situations that I've ran into.
Well, what's interesting, and we'll talk about the connection between domestic and sexual violence and mental health more. But I think one thing that we see a lot in domestic and sexual violence advocacy services is that a lot of survivors of violence will, for a number of different reasons, leave an abusive relationship when they become pregnant. And so it's very common for domestic and sexual violence advocacy programs to be providing services to pregnant survivors. It's just very common. And so I can see how this would be a really helpful resource as advocates are trying to provide services and connect survivors with very comprehensive, holistic services that are available in the community. So in addition to this care coordination, you mentioned that you all also do community education, which I think is a really important piece. Because there is such a lack of awareness, I think, around the issues of mental health and pregnancy. And I think a lot of benefit from providing education to the community on that. So could you tell us a little bit more about the trainings that you all do and how people can participate in your trainings?
Sure. So this is the second set that I've been involved in. I did an anxiety one in the fall, and then the other two reproductive psychiatrists did substance abuse ones in January. We're doing them quarterly right now, and then we're getting ready to do these depression ones today and tomorrow. So mine's going to be on evaluating kind of preconception counseling, since I see that a lot in my outpatient practice, and it's what I strongly advocate for. If you have the ability to talk with us before you get pregnant, that's the most ideal time. And then tomorrow, Dr. Bridget Galati is going to be talking about treatment during pregnancy and postpartum of depression. And then we're going to pick topics for the next couple quarters soon. So these kind of run the gamut. Our team has somewhat solicited input on what areas would viewers want to hear about. So we've kind of just started with what we think are more bread and butter, and probably my presumption would be that over time those would hone down and maybe be even more specific areas of content. But these are provided not just for registered individuals. I mean, certainly they hear about it first, and then they have more of the access to recordings and things like that afterwards. But they do really open it up and use it as an opportunity. It's almost like advertising for MHAP also. Here's the people you would be doing consults with. Here's approaches to things. Because long term, we're hoping that people just are more well-versed and feel more confident in doing these assessments and wouldn't even necessarily need to call us for a consult on things. But right now, we're really just trying to make people be aware that we exist, because we have been around over a year, but we still have so many people that need to know that we exist and so many people to register to take advantage of the services that we provide. Because I still, most of the time, if I talk to an OB-GYN, they don't even know that we exist. And certainly primary care, other psychiatrists, therapists. So it's to provide literally the information in the moment, but then also to make its awareness that we exist and the importance of it. Which is similarly, as I was reading about your organization, and probably I didn't know anything about it until we started talking about doing this conversation. And I was thinking same sort of thing. The beauty of these sorts of connections is that we each get to learn more about the services that the other one provides.
Yes, I could not agree more. And why I'm so grateful that you are joining me for this discussion today, just to get the word out, I think is so important. And for anyone who is also interested in continuing education around the issue of pregnancy and domestic and sexual violence, the Missouri Coalition Against Domestic and Sexual Violence partnered with the Department of Health and Senior Services recently to develop an online 2-hour-long training called Responding to Domestic Violence with Pregnant and Postpartum Patients. It's available for free for coalition members and the general public as well, and CEUs are available. So I'll go ahead and put the link to that online training on the show notes to this episode, because there's so much to be gained by just sharing information, as you said, Dr. McKean. As we are kind of wrapping up our conversation about the Maternal Health Access Project specifically, before we move on to larger issues and dynamics that exist between domestic violence, sexual violence, mental health, and pregnancy, is there anything else you wanted to be sure to talk about related to the Maternal Health Access Project?
I think so. I just hope that, again, it's something that if you hadn't heard about it before, that you're interested in, and take the 2 to 5 minutes to just go register, because, again, it's free. You never know when you might need it. And we are available 9 to 5, Monday through Friday, to provide these sorts of consultations. So we really just want to make sure that people know that we exist and spread the word.
Wonderful. And the Maternal Health Access Project is a statewide program. And as you mentioned before, Missouri is a state with some very metropolitan areas that have dynamics at play and rural areas that have other dynamics at play. Could you speak to what experiences you're seeing as a statewide project working in urban and rural areas. What differences are you seeing in patients' experience?
Well, most of the calls I've gotten have been from more rural areas. I would say the vast majority that I've gotten have actually been like from the southwest part of the state in the Joplin area. And I think that that's potentially been true for the other psychiatrists that cover this as well, but then some even like out in Franklin County too. So just a couple of the counties, you're somewhat close to larger places, but still far enough away that even if the clinicians themselves can make it to like continuing education and those sorts of things, still their patients cannot, or they do not have, again, a wealth of resources. Because even in the state of Missouri, even in the St. Louis area, there's only a handful of us that like work in this space, in this kind of reproductive psychiatry space, but we don't exist like throughout any of the rest of the states. In some ways there's a lot of similarities, because even though we are around, if we're either in academic centers or in private practice, you still may not be able to just like immediately get to care with us, even if you're in the urban area. So honestly, those that are taking advantage of the consultation have quicker access to us than somebody that is just trying to see us at our actual practices. But we see like really similar sorts of things. I think, again, it's so commonplace to experience depression and anxiety, again, regardless of where you live. It's just there can be like significant other barriers if you also have transportation issues, nutrition issues, substance use issues. Like you start layering on like other areas, and that can make it much more difficult. And if you're in a more rural area, then there is farther to travel, which incurs more expense. And there's just a lot of other barriers to think about in the more rural area than urban. But there's plenty of folks even in the St. Louis metropolitan area that are struggling for access to care, for sure.
Right. I can certainly see the benefit for both urban and rural areas. And so glad to hear that you're able to connect with providers in rural areas. I think that's so important. And I hope that you keep the momentum going on that one as well. So I have to say, when you were working, domestic and sexual violence are such prevalent issues that when you are working with the public, you are going to be working with people who have experienced domestic and sexual violence. And I also can see, after the information you've provided about the Maternal Health Access Project, how it's really a promising practice for improving maternal health outcomes in the state of Missouri. And I would say that domestic and sexual violence advocacy programs are also very interested in improving health and promoting health equity in the state of Missouri. Okay, so in Missouri, the Department of Health and Senior Services hosts a project called the Pregnancy Associated Mortality Review, the PAMR. And the Pregnancy Associated Mortality Review looks at maternal death in Missouri to identify what the root causes of these deaths are. And interesting for our conversation, and I'd love for you to weigh in on this, is that it has identified that mental health conditions are the leading cause of maternal death here in Missouri, and that actually domestic violence is the third leading cause for maternal health here, for maternal health death in Missouri. And so I was wondering if you could just speak to this connection of domestic and sexual violence and pregnancy, and how are these two issues related, and how are they both causing maternal death here in Missouri?
Sure. So trauma is one of those things that I always screen for. I wouldn't say necessarily in our consultations, because those tend to be very focused, but in any time in an outpatient situation, I am screening for that. And I feel like if you aren't, then you can be missing quite a bit about what is leading to somebody's pathology. So there can be times I've been talking with somebody for 30, 45 minutes, and then I ask them about trauma, and then they go into a very lengthy description of some pretty significant life events. And it kind of makes some of the other things really make sense. Or sometimes I am just shocked that somebody has honestly persevered despite whatever that life experience might have been. But again, I think that knowing those sorts of things, if someone's experienced, whether it's verbal or emotional abuse, physical abuse, certainly sexual abuse, assault, domestic violence, is critical in understanding their relationship with themselves, their relationships with those around them, in an assessment for pregnancy. Maybe it's an infertility assessment, pregnancy, postpartum, and seeing kind of where they're at and their comfort level with all of that. Sometimes, especially if the perpetrator is who is, maybe the father of the pregnancy. So, but if for those that don't know, I presume, Nora, you know this, but if you are pregnant and in a relationship with somebody that has been abusive, it's a pretty good chance that abuse is only going to heighten. It's very maybe the opposite of what you would think is like, oh, if she's now pregnant with a child, then maybe that abuse or that violence would decline. And most of the time it doesn't, which is why then sometimes it ups the ante for maternal morbidity and mortality that is linked to that abuse or physical violence versus the morbidity and mortality that's more directly related to mental health issues, which might be somewhat self-inflicted. But sometimes even in a domestic violence situation, the morbidity and mortality is self-inflicted because the individual just feels like they're really in a position where they can't imagine like living, and they can't imagine living and bringing a child into that situation. So sometimes something that they've been willing to persist with over time, once pregnancy is part of the picture, like changes some of the thought patterns. So it makes complete sense to me that those two are both high on the list of morbidity and mortality, but also such interconnectedness to them. And I think, we talked somewhat about this earlier, but both of these areas, there's so much stigma associated with that. There's so much fear about being open and honest. And frankly, when it comes to domestic and partner violence, that fear isn't necessarily unsubstantiated. Like, it can be extremely real. And so people being able to find people that they trust to talk to about it is so important.
Yeah.
So I think it's understandable that individuals that have sustained that and been able to remove themselves from those situations are still going to be experiencing a significant amount of mental health issues, because getting out of the situation is only like step one.
Yeah. One of the things I really appreciate about the Maternal Health Access Project is that you view pregnancy as an entryway to connecting with supportive services. And so if you're experiencing domestic violence as part of your relationship or sexual assault, and you're getting services through perinatal care for your pregnancy, it is a great entryway to connect with advocacy services. And I also really appreciate how you talked about screening for domestic and sexual violence, screening for trauma, and that it's a missed opportunity if you don't. Because we do know that many survivors are not going to just volunteer that information or ask for supportive services. They're much more likely to engage with services if they are asked if this is something that they're experiencing, rather than just leaving it up to them to be volunteering that information. So that proactive approach can really make all the difference in the world. One thing that we see a lot when we talk about experiencing domestic and sexual violence is reproductive coercion. It's a tactic of abuse that's very, very common. And as a reproductive psychiatrist, I would love to hear your thoughts on reproductive coercion and if it's something that you see in your practice.
I've seen it sometimes. I've seen it more earlier. The practice I have now, I don't see it quite as much, but you would still be surprised. I do see a lot of manipulation. And for those that aren't aware of what reproductive coercion is, it is where there is like a power play somewhat over reproductive rights. And I certainly within a relationship, I should say. And that certainly I've seen that come to play in some patients of mine, even in my outpatient practice, especially with certain other hot topics in our state as far as like access to care and those sorts of things. And what I've seen most commonly is, maybe there's been a pregnancy that there was a lot of postpartum comorbidities, whether not necessarily as the mental health part, but maybe like cardiovascularly, like bleeds, like things where maybe their team is saying, you probably shouldn't get pregnant again. And they have a partner that isn't amenable to taking the steps to make sure that that doesn't happen because of, at the end of the day, again, just exerting power and exerting control over the situation. But a lot of women in other kinds of relationships, just even if they aren't interested in becoming pregnant or they want to stay on their birth control or something like that, and if they have a partner that kind of thwarts that, whether that is like literally throwing away their birth control or it is quote unquote forbidding them from having a procedure done that might keep them from getting pregnant. And so that's just a lot of people don't know about that or think about that as far as some of these dynamics with kind of intimate partner violence. But that is certainly one that I've seen that I think sometimes even my own patients don't really realize would kind of fall under that umbrella when they're having those conversations with their partners.
And we've seen some positive movement in Missouri on some legislation that would allow survivors of domestic and sexual violence or allow anyone to get divorced while pregnant. And that is really important for survivors because of these issues around reproductive coercion. And sometimes their partner will interfere with their birth control methods or through other methods keep them pregnant so that they can't get divorced and they can't leave the abusive relationship. And so we'd be really excited to see that get passed during this legislative session. More to come on that for sure. You've talked about how experiencing domestic and sexual violence can impact maternal health, but I'd love to hear your thoughts on how these experiences of trauma can impact mental health specifically. What kind of mental health impacts does experiencing domestic and sexual violence have on an individual?
Having trauma certainly puts you at risk for other types of trauma. So if you've had a traumatic experience and then have other sorts of events in your life, you are more prone. So I think to just increase, it just ups the ante for subsequent episodes of acute stress disorder or a post-traumatic stress disorder, even in domestic violence sort of situation. So I think it kind of, again, like sets the threshold a lot lower. So that's not something that people like really know about or think about. And then just in general, I think that strategies that those that have endured a abusive relationship that they've had to kind of put in place, again, sometimes puts them in a situation where it's difficult to engage. It's difficult to always have trust and interpersonal relationships. And then that can then lead to struggles with depression, with anxiety, and sometimes even with like feeling kind of what we call anhedonia, kind of feeling like blah and not being able to have emotion because they had to, again, utilize other strategies, sort of self-preservation and protect themselves. So I've had some kind of be like, I want to be more engaged with my partner. I want to be more engaged with my children, but something's still keeping me from being able to do that. And then other things we think about, like people do have, if you've heard of like depersonalization, derealization, or people are worried that they're having a psychotic type episode, that they're like hearing things, seeing things. So these are all sorts of like screening tools that can be important in working with patients that have endured some sort of trauma, especially violence, because you can unfortunately like have what's called re-experiencing. That's one of the triad of things when you're diagnosed with PTSD, is that you re-experience things. And so it can be hearing a voice of a perpetrator. It can be like driving past a place where something happened. It could be a smell. It could be a meal. It could be a song that comes on the radio, like anything that can sort of like jar a memory of that can certainly impact a person's ability to feel present and enjoy things going on currently, even if they are much removed from that prior traumatic relationship.
And so if a service provider, say, for example, a domestic or sexual violence advocate, is working with a survivor who's experiencing some of these mental health impacts from the trauma, what recommendations would you have for that service provider? How could they best support that survivor?
Sure. I think a combination of both getting connected with a therapist that has certainly, they don't necessarily have to be trained in EMDR, but I'll talk about that in a second. But at least that they're what we would call like trauma informed, that they understand, again, like all of the variety of presentations that could come from somebody who's experienced trauma. So somebody that's definitely going to not be afraid to talk about those sorts of things with this person, but also be sensitive to, for instance, like when I do an initial evaluation, like, and I ask about, have you ever experienced like this, and this? And if they are like, yes, but I don't want to talk about it, I respect that. And I say, okay, we definitely do not have to talk about that today. We don't necessarily have to talk about it ever, but, once you maybe trust me a little bit more, feel more confident, if you are willing to, I'm here to support you for that. So you have to have folks that know how to do that. So, being linked with a therapist, probably first and foremost, because most people still, it's a lot more palatable for them to be referred to a therapist or a counselor first. Mm-hmm. But then in those other conversations, if someone's having sleep difficulties, if someone's having panic attacks, if somebody's having, I say persistent and bothersome mood and anxiety symptoms, then kind of like helping them to understand that there are other ways to support that. And that might be like talking with their primary care doctor, talking with whomever they trust, that might also be able to provide at least an evaluation and recommendations on either over-the-counter or prescription medication, because these things can be helpful. It doesn't always have to be something that's like long-term, but a lot of times with trauma, it's helping with acute, like to do the right kind of like psychotherapeutic processes you need to do that can exacerbate symptoms to a point that interferes with the psychotherapeutic processes. So it's kind of like they work in tandem. So oftentimes I'm prescribing things that help to turn the volume down on symptoms so that somebody can do the right type of psychotherapeutic modality, which with trauma, one of the most recommended is what's called EMDR, which is, and I always mess up this acronym, but eye movement desensitization and reprocessing treatment. And that used to be something that hardly anybody, it seemed like, was trained in, but has become more and more common. And again, kind of like dialectical behavioral therapy or DBT, that used to be felt like it was only for borderline personality disorder. And now we see its value in treating a variety of things. EMDR is the same sort of thing. It's a very focused type therapy for those that aren't aware of it. It does not have to be something where you're seeing someone forever and ever and ever. It can be for one situation and helping to kind of desensitize and process that, or it can be tackling multiple different ones, kind of one at a time. So that may have been a long-winded answer to what you asked.
No, I mean, we've heard some really great feedback about survivors who've had EMDR therapy and just supported their healing process really extraordinarily. And so it's really good to hear that you've had similar experiences. Mm-hmm. So is there anything else that you would want to say about modalities that you have seen to be particularly promising with survivors of domestic and sexual violence or people who've experienced trauma? You mentioned EMDR. Is there anything else in your practice that has been really promising?
I would say the thing that I've seen evolve the most over time, and I mentioned it previously briefly, was DBT, or dialectical behavioral therapy. So that, again, was initially formulated for individuals with borderline personality disorder, because what it does is it's a very concise description of it, is it's really just helping people to handle conflict and handle intense emotions based on interactions. And I think that that's something that you don't have to have experienced trauma, but I definitely think if you've had trauma, you might be more prone to, depending on somebody's interactions with you. You might find yourself reacting in a way that you don't feel like you have the best control over. And so that type of treatment really helps people to identify how they react in certain situations that might be maladaptive, ways to kind of not go from 0 to 60 in 3 seconds, and to what's called chaining, really identify what was I feeling and thinking, a few seconds before maybe I had the outburst, or some other sort of explosive situation. And I think that just as a therapeutic modality, I've seen again evolve over time, where I've had a lot of people with anxiety, with depression, with just things that they don't have a personality disorder at all, but have found that to be just really helpful for them to improve their relationships. And so I think that is something that could work in tandem with EMDR and other sort of trauma-informed treatment, because for a lot of people, it is really building back trust. Mm-hmm. If they've been in a situation where they felt like there's nobody that they can trust and they've been very isolated, then they really have to, it's hard work. It's unfairly hard work for them to have to figure out how to just exist in the world and interact with people again, and not just expect that everybody is going to have some sort of want to harm them in some way.
Yes, absolutely. Thanks for speaking to those. We hope to see more widespread use of these practices to improve maternal health in Missouri. So really great to hear that you're getting positive results from them. This is the May episode of Momentum for Change, and May happens to be Maternal Health Awareness Month. And so this is a time where those of us in the field raise awareness around well-being before, during, and after pregnancy. And as a reproductive health psychiatrist, I would love to hear your thoughts of what there should be more awareness around when it comes to maternal health. Anything that you would like to just put out there and promote?
Well, again, I feel like I do this all the time, but I definitely do take the opportunity of really honing in on May and maternal mental health awareness. There's certain days, I think it's the first Wednesday of the month is the Maternal Mental Health Awareness Day, and making sure to share everything there is worldwide, because there are programs throughout the world that are highlighting these sorts of things. I would say, while we have a lot of awareness here, some places are certainly doing it better. And so I just use it as a platform to provide even more information about how common these things are. Again, as you mentioned earlier, as far as things that are high up on maternal morbidity and mortality, any opportunity I have to talk about depression and how depression and anxiety is the number one comorbidity of pregnancy, and how it's so important that these things are being screened for, even in those that have never experienced them. It doesn't, if you're 40 years old and pregnant and you've never experienced any mood or anxiety, that doesn't mean that you can't experience it during pregnancy and postpartum. And I think just really trying to destigmatize mental health concerns and really be that like mental health is health. It just needs to be ingrained in the entire sort of like perinatal process, the same way they're checking for, for growth, the same way they're checking blood sugar, they're checking blood pressures, protein in the urine. There should just be same sort of incremental screenings for mood and anxiety throughout. And I know different agencies are working towards making that be a reality. Because of the lack of services in this area, sometimes that's what's holding some of it back, is because you can screen all you want, but if you don't have people to refer them to, then
right.
But we do know how commonplace it is. We do know what significant comorbidity it can have in relationships in families, because it doesn't just stick with the mother in this situation. Like it ekes out into other parts of the family, other parts of their relationships. And so it's so important to be addressing it early on and intervening as soon as possible. And again, that doesn't always have to be medication. That can be like non-pharmacological strategies as well. But another thing that one of the goals with my practice is also to make it more mainstream that treating these things is important and isn't something to be afraid of. And that a lot of times it's the first thing that, if somebody finds out you're pregnant, they're like, stop your medications. And they wouldn't do that for certain health conditions, but they will often, do you really need that? And I pride myself on being somebody that I only recommend things that I think my patients need. And so, no, I don't think that but I can't tell you like how many patients come to me because they were told that they couldn't stay on the medication that they were on. And it's something that at the end of the day is like really, really safe, really, really conducive to pregnancy. And that actually them coming off of it is what is going to actually potentially cause more risk for their pregnancy, whether that's them continuing with care, whether that is if they fall into like a deep depression or a manic episode or psychosis. Like there are so many things that can then lead to that are so detrimental versus a medication exposure. Now, I say all of that, and then it also is important for patients to be part of the process. It isn't just like, oh, stay on that medication and I don't need to tell you why. It's important that they know what their diagnoses are, why they're prescribed the certain medications, what those risks really are, so that they can make informed decisions. And if I have a patient that has bipolar disorder or a history of psychosis, and they are adamant that they do not want to stay on medication, I have to meet them where they are, because I would much rather them still like think that I am their advocate and I'm with them and that they're at least still coming to see me, even if they have stopped their medication, and we make a plan for like, okay, but if things start to get worse, here's our game plan. Versus they're like, okay, and they walk out and they're like, I'm not doing that, and then I never see them again.
So many important points you just made there. Thank you for sharing those thoughts. It really shows just how deep your knowledge of these issues are and how passionate you truly are about them. I love that you want more awareness about just how common mental health issues are during pregnancy, because I think it really normalizes not only what someone is experiencing, but it also normalizes getting care and getting treatment for those experiences. So I'm 100% on board with that message as well. And I'm so glad you spoke to it.
Thank you.
And so as we're wrapping up, given your experiences in the field, what are your hopes for the future of perinatal psychiatry? What would you like to see?
If I could have anything I wanted.
All your wishes are granted.
Yes, there you go. Poof. I don't want people to feel ashamed, and I don't want others to try to make them feel ashamed of seeking this care. I still have folks who see me who aren't telling their other doctor. I still have folks who see me who aren't maybe telling their partner sometimes. And then I have it runs the gamut though. Then I have the others where like the partner is the one super advocating for them. Like, yes, I really want them to see you. They really need this. So, I think it's kind of been what's kind of like been the undercurrent of our entire conversation is that, this just needs to be mainstream. This just needs to be not something that we have to have special conversations about. That is just part of the process. That is something that people recognize, like, I could be at risk for this, or I already am at risk for this. And so I need to have this person as part of my team. I have rarely had somebody that looked back on things and were like, I wish I wouldn't have had more people to help me. Right. Like, I don't know that I can ever think of somebody saying that. I've definitely had people say, man, I wish I would have done X, Y, and Z, whether that was take that medication, at least be seeing you, seeing a therapist, doing X, Y, and Z for my mental health. Wish I would have set more realistic expectations. Wish I would have had those conversations with my other members of my treatment team, because sometimes it is me being a liaison between my patient and the other members of their team. So when they're getting conflicting information, that I have to help them to make choices and help them to still trust their obstetrician, even if they're telling them something that maybe differs from what I said, because they like both of us and they want to keep both of us. But how do we navigate that? So a lot of my training back in that residency stuff was being what's called consult liaison psychiatry. And so I've just kind of kept those tenets going. And that's what I would hope for, is that when I do reach out to those clinicians, they're also like, oh, I'm so glad that like you're a part of their team, that they're seeing you, because honestly, it takes a weight off of me. And now I don't have to worry about that. But I know that like we all have the same goal.
So your vision for perinatal psychiatry is that it's not just like an other part of pregnancy care, but it's incorporated into the totality of what somebody's pregnancy care would look like. Beautiful.
Yeah, it should just be integrated in.
Love it. As we're wrapping up, Dr. McKean, any final thoughts you wanted to be sure to share today?
I just hope that anybody listening, whether you're new to hearing about the Maternal Health Access Project, or perhaps even new to hearing about all of the domestic violence work that's being done. I know I learned a lot in preparing for this conversation that I didn't know existed. And I think the flip side was true. And I think we can all benefit from like learning more and being educated more. So I just hope that people listen and they take a couple gems from our conversation and use that in their everyday work and life.
Absolutely. Well, thank you so much, Dr. McKean, for joining the conversation today.
You're welcome.
We certainly appreciate it. And I did get so many little gems from the insights that you shared. So thank you so much for that. And thank you, listeners, for tuning in. We hope to see you next month for a new episode of Momentum for Change. Thank you for joining us. This has been a recorded conversation, now available in both video and podcast formats. A video recording of this episode is available on the MOCADSV YouTube channel under the Momentum for Change playlist. Please subscribe to our YouTube channel in order to receive new episodes in your YouTube feed. You can also find all of our Momentum for Change episodes available to stream on Spotify or wherever you find your podcasts. Momentum for Change is a podcast produced by MOCADSV with post-production support provided by Tim Stillings and promotion by Adrian Maddox. Again, I am your host, Nora Mosby, and we appreciate you joining us for this episode. Thank you again, and we look forward to seeing you next month.